Yes, sir, we are loud. You can start.
Yeah, thank you very much. Um, so, welcome you all delegates and all the audience for giving your precious time for today's program, which is being sponsored by Zydus Synovia. And we are welcome you all for this RUMA DG Conclave. Uh, the concept of this DG Conclave comes from the very beginning of the objective of sharing knowledge from a veteran rheumatologist to uh, the all you audience. And that's why today we are having Dr. Durgesh Srivastava. Dr. Durgesh Srivastava is from Lucknow and he is a consulting rheumatologist. He is with us as a super specialty doctor, and he will be sharing his experience and knowledge about the uh, rheumatology. And today's topic is status of rheumats in rheumatoid arthritis. So, first of all, thank you very much, sir, and welcome to the webinar. And thank you very much for giving us this opportunity.
Thank you so much for this opportunity.
Thank you very much, sir, for joining us and sharing your knowledge and taking your precious time for all of us. So, to introduce sir, I would like to say, sir is a consulting rheumatologist. Sir has completed DM in rheumatology in July 2017 from the King's George Medical University, Lucknow itself. As far as work experience is concerned, sir is in private practice since August 2017 and also working as a and in various hospitals at Lucknow and other cities like Prayagraj, Kanpur, Sultanpur, Gorakhpur, Shahjahanpur, and Hardoi as a visiting consultant. Sir is a member of Indian Rheumatology Association, uh, which is well known and well recognized in India for all the rheumatologists. As far as certifications are concerned, sir has completed EULAR, which is European League Against Rheumatism, online course in 2015. And more than 10 posters has been presented by sir in various rheumatology conferences, national as well as international. And more than 8 papers has been published till now in various national and international journal by the sir. So with all this vast experience from our veteran rheumatologist, I must say, and upcoming and budding rheumatologist, I must say, Dr. Durgesh Srivastava, I welcome you and session to you, sir. Now you take over and the session is status of DMARDs in rheumatoid arthritis. Over to you, sir. Thank you.
Thank you for the kind introduction, Vishal.
Yes, sir. I have stopped sharing. Now you can upload your presentation.
Okay,
and take us through the entire program. And I would like to tell all the audience that at the end of the program, after maybe 30 to 40 minutes, you can ask your question in the chat box. I will read your questions and then we'll get the answers from Dr. Durgesh Srivastava.
Fine. So good evening, everyone. So today I've been allotted this topic of status of DMARDs in rheumatoid arthritis. And I'm going to give a brief about this because it's a very large topic. There are so many agents used. So I'll start with the contents of my talk will be introduction, then drugs used in RA. And amongst these main role and importance of DMARDs, and then I'll conclude. So to start with the introduction of rheumatoid arthritis, it is a chronic inflammatory disease of unknown etiology, which is marked by symmetric peripheral polyarthritis causing joint damage and physical disability. The most common age of incidence is between 25 to 55 years of age, and it is more common in female than male. And the ratio is 2.5:1. The main signs and symptoms of this disease include early morning joint stiffness and pain in small joints and swellings in small joints of hands and feet, including MCP and PIP joints. Even the large joints are also involved, but they are less common than small joints. Coming to the pathophysiology of RA, inside the joints there is a synovial inflammation and hypertrophy, which is proliferation, and there are focal bone erosions. So this is a normal bone, and here you can see the erosions in the bone. And this is the normal amount of synovium, very thin, and here it is largely inflamed and boggy swelling present. It leads to thinning of articular cartilage and bone damage and joint damage. So the inflammation is primarily mediated by T cells, B cells, plasma cells, dendritic cells, mast cells, and granulocytes. And the T cells are major component, and they comprise almost 30 to 50% of the total cell infiltrate. And if the patient is not receiving proper treatment and timely interventions, then joints become deformed, and it may lead on to various types of deformities like these. So coming to the modalities of treatment in RA, there are various modalities available, which include non-steroidal anti-inflammatory drugs. Uh, they were earlier the main cornerstone of treatment of RA, but after the advent of DMARDs, they have become less preferred now because of various side effects which occur due to prolonged use of these non-steroidal agents. The main drugs which are commonly used include diclofenac, ibuprofen, aspirin, celecoxib, and all of these are used as only adjunctive therapy, and preferably for the time until the classical DMRs take on their action. Second group of drugs is glucocorticoids, and they include mainly prednisolone and methylprednisolone. They are used even more rarely because of side effects, and they are usually given only for acute flare-ups when other drugs take time to act. These act very fast. They have onset of action within hours, so patient gets instant relief, but they should be given only for very short periods of times. Now, the third group is conventional DMRs. They include methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide, etc. The fourth group is biologic DMARDs. There are various categories in biologic DMARDs, including anti-TNF agents like adalimumab, infliximab, etanercept, sectolizumab, golimumab, anti-IL-6, which is interleukin 6 agent. It is available as a brand Actemra, which is tocilizumab. Then third group in this is anti-CD20 agent, which is rituximab. Fourth one is anti-CTLA4 available as abatacept. And then there are oral biologics which are available as JAK inhibitors, for example, tofacitinib and baricitinib. And upcoming newer DMRs, which are conventional DMRs, are also there, which include recently launched iguratimod and tacrolimus. Even though tacrolimus was available for a long time, its use in RA has been established over past few years only. So now I will go on to status of DMRs. So DMRs are primarily the drugs which decrease the inflammation in the joints. So by that they improve the signs and symptoms of disease, and they lead to reducing the speed of bone damage and decreasing the disease progression associated with RA. So the current therapeutic landscape of rheumatoid arthritis includes first is methotrexate is the first drug of choice in early rheumatoid arthritis, which is a mild to moderate severity. And the next landscape includes development of novel, highly efficacious biologicals and other agents that can be used either in alone or in combination with methotrexate. And the third one is to combine various DMARDs as a regime and prefer it above using methotrexate as a monotherapy. So now coming to conventional DMARDs. The first and the foremost is methotrexate. Uh, it is a non-biologic anti-metabolite which is used in most commonly used DMARD and is used in around 50 to 70% of rheumatoid arthritis patients. Its mechanism of action includes inhibition of aminoimidazole carboxamide ribonucleotide transformylase enzyme, which is also known as AICAR, and thymidylate synthetase enzyme. So these two enzymes are inhibited by this, and with the chain of reactions which take place, but this inhibitions leads to inhibition of inflammation by suppression of macrophages, dendritic cells, lymphocytes, neutrophils, and stimulation of apoptosis of these inside these cells. So by this, the anti-inflammatory action takes place. Methotrexate also has a secondary effect on dihydrofolate reductase enzyme, and this action affects the lymphocytes and macrophage function and leads to inhibition of pro-inflammatory cytokines, which lead to joint damage and inflammation in the joint. So coming to the pharmacokinetics of this drug, it is 70% metabolized after oral administration, and its half-life is 6 to 9 hours, and it is excreted mostly in urine and 30% as in the bile. So even though its half-life is only 6 to 9 hours, it is used only as a weekly therapy, with the doses being between 10 to 25 milligrams, depending upon the severity of disease and control of disease. So this is because the action is not desired continuously, and pulses of the drug every week are required, so that the normal cells of body are not affected due to this anti-metabolite function. Otherwise, if it is given more regularly, like daily, if the patient takes it daily, they invariably land up with side effects like mucositis and bone marrow suppression, etc. So because of these side effects, the folic acid, which is a vitamin which is given on next day or two after methotrexate to decrease the incidence of drug toxicity. So fine, the methotrexate has been shown in various randomized controlled trials to reduce the appearance of new bony erosions and slow the disease progression. The main side effects include nausea, mucosal ulcers like oral aphthous ulcers, drug-related hepatotoxicity, leukopenia, anemia, and gastric ulcerations. Coming to the next DMARD, which is conventional synthetic DMARD, it is hydroxychloroquine. Its mechanism of action involves suppression of T cell responses to mitogens, decreased leukocyte chemotaxis, stabilization of lysosomal enzymes, trapping of free radicals. And with these actions, it reduces inflammation. However, its action is only modest as compared to methotrexate. And it is rapidly absorbed in the body, and it is metabolized in liver. The half-life of this drug is 45 days. But to maintain optimal blood levels, it has to be given daily. And coming to its dose in rheumatoid arthritis, the usual dose which is given is 200 to 400 milligram per day, and it has not to be exceeded 400 milligram. But recently, past 1 or 2 years, the guidelines have mentioned that dose has to be individualized in every patient, and according to the body weight, it has to be maximum 5 milligrams per kilogram per day, not to exceed 400 milligrams daily. It takes 3 to 6 months for response, and it has no effect on bony damage in RA. As I told, its effect is only modest. Side effects include rare ocular toxicity, so eye examination at baseline is must, And after 4 to 5 years of treatment, every yearly eye examination should be done. And other side effects include nausea, vomiting, rashes, which are rare. The next agent in the synthetic conventional DMARDs group is sulfasalazine. It has two components, which are sulfapyridine and 5-ASA, which is also known as mesalazine. And the sulfapyridine is the active moiety against arthritis. It decreases the production of IgA and IgM and inhibits the release of inflammatory cytokines produced by macrophages and monocytes, for example, IL-1, IL-6, 12, and TNF-alpha. It is sparsely absorbed orally, and only 10 to 20% is absorbed. And it some fraction undergoes intrahepatic circulation. The half-life is 6 to 17 hours, and it is excreted unchanged in urine. So because of less absorption, the dose required is higher. And initially, the dose has to be given at 500 milligram twice daily for 4 to 5 days, and to observe for any side effects like allergic reactions. And if the patient tolerates it, the dose for maintenance is 1 gram to 1500 milligram twice a day. And it has also been shown to reduce radiologic disease progression in RA. Usually, it is given in combination with methotrexate and hydroxychloroquine. The main side effects include nausea, vomiting, gastric side effects like bloating, hemolytic anemia seen in G6PD deficient patients. Methemoglobinemia and neutropenia are rare side effects. The next agent in this group is leflunomide, and its mechanism of action involves inhibition of dihydroorotate dehydrogenase enzyme, and decreases the RNA synthesis. So by this, it inhibits the T cell proliferation and production of autoantibodies by the B cells. It also decreases interleukin 8 and interleukin 10 synthesis and TNF alpha dependent nuclear factor kappa beta activation. The dose in rheumatoid arthritis is 10 to 20 milligram per day, and half-life is 19 days. And its action are similar to methotrexate in prevention and progression of the disease. The side effects include diarrhea, weight gain, deranged liver function test. Sometimes hypertension is also aggravated by this agent. Coming to the next candidate in this conventional synthetic DMARD group, it's a newer DMARD which is introduced recently. It is known by the name of iguratimod, which was developed in China and Japan. And its mechanism of action involves inhibition of production of immunoglobulins and inflammatory cytokines like IL-6, IL-8, and tumor necrosis factor alpha. It also exerts anabolic effects on bone metabolism, and it inhibits osteoclastogenesis, thus thereby preventing osteoporosis associated with arthritis. It inhibits NFKB activation, and this action leads to its additional property of COX-2 inhibition. By this way, it also acts as an analgesic. So it may be called as a 2-in-1 drug because it's a DMARD also, and it also acts to reduce the pain. Its efficacy and tolerability are comparable to sulfasalazine and methotrexate. The dose in RA is 25 milligram once or twice daily as per the disease requirement. And several studies have demonstrated its efficacy and safety of monotherapy as well as combination therapy with other DMARDs in patients who had inadequate response to methotrexate and other combinations. The chief side effects include thrombocytopenia and deranged liver enzymes. So monitoring has to be done promptly. The next candidate in this newer DMARD group is tacrolimus. It is a calcineurin inhibitor, which reduces proliferation of cells and leads to inhibition of T cell activation. The dose in rheumatoid is 0.25 milligram to up to 2 milligram per day, as the patient tolerates or as the disease activity requires. It has been shown to be an effective and safe therapeutic option in RA patients who are intolerant to or resistant to previous DMARDs. In addition to monotherapy, it has been also successfully used as a part of combination RA therapy with methotrexate. Its side effects include tremor and nausea. Pancreatitis has also been seen. Deranged renal functions are also seen. So the serum levels have to be frequently monitored to prevent its toxicity. Other less commonly used DMRs include azathioprine, cyclophosphamide. They are mainly used in patients with RA who have comorbidities like interstitial lung disease, because in such patients, methotrexate may aggravate ILD. It has been classically told, but recently methotrexate has, in larger studies, it has not been found to aggravate ILD. So um, currently there is nothing against methotrexate in ILD. Mycophenolate mofetil is another agent which is used in RA-ILD. It has almost no efficacy for arthritis. Other classical DMRs which were used in the past include D-penicillamine, minocycline, chloroquine, but they are rarely used nowadays because of much better options available. Now coming to the biological DMARDs. As I told, this group has many various types of molecules. So first one, anti-TNF agents, and the main agent and classical one is infliximab. It is a chimeric protein, 25% mouse and 75% human IgG1 monoclonal antibody. It binds with high affinity to soluble and membrane-bound TNF alpha, thus it inhibits TNF alpha function. In rheumatoid, it is used with if used with methotrexate, it decreases the formation of new erosions more than methotrexate alone or infliximab alone over 1 to 2 years. The usual doses is 3 milligram per kilogram intravenous infusion at 0 to 6 weeks and then at every 8 weeks. It may increase, we may increase the dose up to 10 milligram per kilogram every 4 weeks and then maintenance every 8 weeks thereafter. Half-life is 9 to 12 days, and the main problem with these agents is side effects, which include increased incidence of infections like respiratory tract infections, activation of latent tuberculosis, and increased positive incidence of ANA and DSTN antibodies. It may even induce lupus in a patient. So screening for latent tuberculosis has to be done before starting these agents. Apart from this, cardiac patients who have heart failure, they should also be carefully monitored before starting these agents. The next agent is adalimumab. It is more convenient to give because IV infusion is not required. It is fully human IgG1 anti-TNF monoclonal antibody. It complexes with soluble TNF alpha and it prevents its interaction with P55 and P75 cell surface receptors, resulting in downregulation of macrophages and T cell functions. So in rheumatoid, it is effective both as monotherapy and combination therapy with methotrexate and other DMARDs. The usual dose of adalimumab is 40 milligrams subcutaneously at every 15 days, and half-life is 10 to 20 days. And side effects are similar to infliximab. The next agent is etanercept, which is commonly used nowadays. It is a recombinant fusion protein that inhibits TNF alpha. It acts by blocking TNF alpha and lymphotoxin A and decreases the inflammatory reaction. It is also used as monotherapy and also it combination therapy with methotrexate and decreases the rate of formation of new erosions. It is given a subcutaneous injection in 50 milligram dose once a week or 25 milligram bi-weekly. Its half-life is 4.5 days. So side effects are similar to infliximab. However, there is much less incidence of reactivation of latent TB and other infections with this agent. Next agent is certolizumab, which is a recombinant humanized antibody fragment conjugated to polyethylene glycol. So it is also known as certolizumab pegol. It neutralizes the membrane-bound and soluble TNF alpha in a dose-dependent manner, and it is used in moderate to severe RA in the doses of 400 milligram initially subcutaneously at 0 week, 2 week, and then followed by 200 milligram every 15 days. Half-life is 14 days, and side effects are similar to infliximab. Next agent is golimumab. It is a human monoclonal antibody, and it has affinity for soluble and membrane-bound TNF alpha. It neutralizes the inflammatory effects produced by TNF alpha. In rheumatoid arthritis, it is used with methotrexate for moderate to severe active RA, and dose is more convenient with this agent. It is given only monthly, 50 milligrams subcutaneously injection, and half-life is 14 days. Side effects are increased tuberculosis and fungal infections, so the latent TB test has to be done. The next group of drugs is IL-6 inhibitors, which include tocilizumab, and it is a humanized antibody. It inhibits T cells, B cells, monocytes, fibroblasts, and cell proliferation and endothelial cell proliferation. In rheumatoid, it is used in moderate to severe active RA, and dose is 4 to 8 milligram per kilogram intravenously every month. Or if the dose is less than 100 kilogram, there is subcutaneous injections also available recently. So the dose is 162 milligram injection if the weight is less than 100 kilo every other week, and if the weight is more than 100 kilos, then this injection has to be given every week, followed by 8 mg per kg depending on the clinical condition. The half-life is 11 days for 4 mg per kg dose and 13 days for 8 mg per kg dose. The side effects of this drug include increased incidence of tuberculosis, fungal infection, hypertension, neutropenia, and hyperlipidemia. The next agent in the biological DMARD group includes anti-CD20 agents, which is rituximab. It is a chimeric monoclonal antibody against CD20 positive B cells. It stimulates cell apoptosis and decreases inflammation and production of pro-inflammatory cytokines. In rheumatoid, it is used in moderate to severe RA in combination with methotrexate in the patients who are having an inadequate response to one or more anti-TNF antagonists. And the dose of this drug is 1 gram intravenous infusion on day 0 and day 14, and it may be repeated every 6 monthly. And pre-treatment with 100 milligram of IV methylprednisolone is given to decrease the incidence of infusion reactions. The important side effects include increased bacterial infections and rashes, which are presenting as infusion reactions. The next and the latest addition in these biological DMARDs includes this anti-JAK agents, which is genus kinase inhibitors, and it is also known as targeted synthetic DMARD or TS DMARDs. The agent is tofacitinib. It inhibits JAK1 and JAK3, which blocks signaling of receptors for cytokine IL-2, IL-4, 7, 15, and 21. Its effect has been shown to be comparable to adalimumab by various trials, and the dose given in RA is 5 milligram twice a day orally. So it is much more convenient to administer to patient. and it can be given either alone or also in combination with methotrexate. And the side effects include increased infection similar to anti-TNF agents, risk of venous thromboembolism has been also noted with this. So in elderly patients and in those who are at risk of embolism, they should be carefully monitored when they are started on this drug. So other agents in this biological DMARD group, which are available internationally but not so commonly available in India yet, they include abatacept and anakinra. And both these drugs are of different class. Abatacept is anti-CTLA4 agent, and anakinra is anti-IL-1 receptor antagonist. So they are having lesser efficacy as compared to anti-TNF and JAK inhibitors, but they are available for use because in various few patients, other agents may not be feasible. So they are approved, but they are very less commonly used and less efficacious also. So coming to conclude, the main points from this presentation should be: the methotrexate is the first DMARD of choice for initial treatment of mild to moderate RA, but failure of methotrexate as monotherapy now calls for a change to an effective combination regime. So what is the effective combination regime? It it includes methotrexate plus sulfasalazine plus hydroxychloroquine. This is also called as oral triple therapy. And number 2 is methotrexate plus leflunomide. And number 3 is methotrexate plus a biological agent. In the recent ACR guidelines, they have highlighted the need to switch or add a DMR therapy after 3 months of worsening or persistent moderate or high disease activity. So you have to give a combination or a DMR for 3 months and then reassess the disease activity. And if the target is not achieved, then we have to change the therapeutic regime. If still disease activity is high after 3 months of intense DMARD combination therapy, then they say addition of a biological agent is warranted. And with the loss or lack of effectiveness of a biological agent like anti-TNF after being used for 3 months, one should switch to another anti-TNF or another non-TNF biologic agent. So this has been what has been mentioned in the ACR guideline for rheumatoid arthritis. In pregnancy, hydroxychloroquine and sulfasalazine are safest and they are commonly used, while methotrexate and leflunomide are contraindicated. Safety of other biological agents in pregnancy is not yet clear. However, etanercept has been reported as safe by few centers. In elderly patients, the conventional DMARDs and biologic agents are safe and effective, but renal function has to be clearly monitored before starting on methotrexate therapy. And if the renal function is inadequate or below normal, then the doses of methotrexate has to be adjusted and not to be given beyond 15 milligrams per week. So the need for early and aggressive treatment of RA, as well as frequent follow-up visits for monitoring of drug therapy to change the target, to catch the target and change the therapeutic regimes. It has a huge implication on the disease control and prevention of deformities. However, among this discussion, in our country, in Indian scenario, the uses of biologicals is not easy because of not because of much higher incidence of infections or other side effects, but more so because of its high cost. Most of the biologic agents are still costing more than 15,000 rupees per month if they are being given. So they are out of reach of common patients. So thereby, using proper combinations and changing the combinations of classical DMARDs, conventional DMARDs remains the mainstay of treatment of rheumatoid in Indian patients. With that, I would like to conclude the presentation. Thank you so much.
Thank you very much, Dr. Durgesh Srivastav. It's really a nice and pleasurable journey through the entire rheumatoid arthritic treatment, I must say. Though the topic was status of DMARD, but you have taken us through the entire treatment line of rheumatoid arthritis. So that's really a great uh, uh, knowledge for all of us. Moreover, sir, there is a question from the audience, and if audience who is listening to me at the moment, they wanted to ask some questions, they can put it in the chat box. It is there in front of you. You can put your questions there, and I can read it for you with the sir. But yes, there is one question which has already come to us. So the question is, sir, what is your experience and your line of treatment for newly diagnosed active rheumatoid arthritic patients?
For newly diagnosed patients, I assess the disease activity. If the disease activity is mild to moderate, and then I start with methotrexate in the doses between 10 to 15 milligrams per week, along with hydroxychloroquine and non-steroidal agent to be given for pain relief, and of course with calcium and vitamin D as supplements. And I monitor for them for 6 to 8 weeks for changes in disease activity, and increase the doses of methotrexate accordingly up to 25 milligrams. If the patient is having higher disease activity even at the onset or at presentation, then I will also add low doses of steroid, which is methylprednisolone or prednisolone, and up to 8 to 10 milligram per day, so that the disease can be controlled more promptly and more quickly. And then regular assessments at 3 to 4 months. I'll change the regime if the target of disease remission is not achieved by adding another DMARD or changing the regime, or if the patient is having side effects with the combination, then that may warrant a change in the disease drug schedule and drug combination.
Okay. Okay. Thank you very much, sir. Then moving on to the DMARD that actually you have mentioned one novel DMARD, which is igratimod. So
Yes.
what you suggest, shall we use it as a alone or in addition to methotrexate from the beginning itself?
As far as evidence which I have read, I think it is to be used only after methotrexate has failed,
Right.
because that will reduce the incidence of DMARD resistance. Also, we'll have more drugs in our kitty. If we use all of them at the same time, then that will leave us with no drugs if the patient fails on them.
Right. Right. So always better to keep uh, the options available with
Yeah,
us so that we can have some
of
reserved
course.
therapy. Right, sir. In the benefit of the patients. So
Yes.
so with this, sir, questions are over, and I really thankful to you for joining us as a speaker today, and enlightened everyone who has joined today with your knowledge and experience of rheumatology. And being a DMM rheumatologist, you really have done wonderful patient service not only in Lucknow but in around 6 to 7 cities, as mentioned earlier. So that's a commendable job, and I really appreciate your contribution today for this session. So with this, I take your leave, and I really thanks to you once again, sir. And
Thank you
from
so much. I enjoyed the session. Thank you.
yeah, we too, sir. And with this, I conclude the session. And thanks to all the attendees who have attended the program. I thank you, each one of you, on behalf of Zydus Synovia uh, and the entire rheumatology range. Thank you
Thank
very
you.
much. Thank you. Have a good day.